Hi, I am Dr. Felice Gersh, your integrative OBGYN physician. In this segment, we're going to cover another very important topic. Every topic involving women's health is important to me and to you. This one is going to be on testosterone. Testosterone is thought of as a male hormone, and indeed it is. But women also make and need testosterone, and so it's important to understand exactly where testosterone comes from in the female body, what happens with the production, the levels as we age, why it matters, and what we can do about it. Well, let's start at the beginning. What is testosterone anyway? It's an anabolic androgenic steroid. That means it's in the family of hormones called steroids, which are all derived originally from cholesterol, which of course is important to know because cholesterol is not something that's evil, it's critical. If you don't have cholesterol, you cannot make properly any of the steroid hormones, which include such things as cortisol, aldosterone, pregnenolone, testosterone, of course, I just told you that, progesterone, and all the estrogens. So, testosterone is anabolic. What does that mean? It builds. So you have cortisol, which is catabolic. It breaks down. Now you need both. You need anabolic, you need catabolic. Everything in the body is sort of that yin-yang, it's balanced. So it's important to know that as an anabolic steroid, it builds. So what do we always think about it building? Well, muscles, for one. Men love it, but women do too, because muscles are not about just strength, which is very important, strength and balance, mobility, but also it's really important to have muscles because they're also an endocrine organ. Muscles are really important. They signal and they burn glucose, so they're making all kinds of important signalings through mitokines. Very important to have lots of muscle. People who don't have enough muscle have sarcopenia, that's deficiency of muscle state, and they are more likely to develop frailty syndrome, which is very, very bad, and frailty is a bigger prognosis for mortality than even high blood pressure is. So you can see testosterone and all anabolic steroids are critical to functionality, muscle, and bone. So there's lots of data now that very low testosterone in males or in females correlates with bone health and bone density. Now, where does testosterone come from? And we're going to talk a little bit more about what other things testosterone does in the body. So stay tuned, hang on. Well, testosterone, most times when I ask people, including doctors, like, well, in a woman, where does testosterone come from? Well, it turns out that there's a lot of testosterone in a woman, and the majority of it is derived directly and indirectly from the adrenal gland. About 25% of all the circulating testosterone comes from the ovaries, and another 25% directly comes from the adrenals. So where's the other 50%? Predominantly from adrenal androgenic precursors like DHEAS and its metabolite DHEA. A small amount, percentage-wise, of DHEA comes from the ovaries, but the vast majority, at least 80%, comes from the adrenal, and 100% of the androgen DHEAS comes from the adrenal gland. Now, these other androgens, DHEAS and DHEA, can be converted into testosterone. The main place that they're converted in and then circulate is from adipose or fat tissue. So it's important to know that those androgens get converted to testosterone and circulate in the woman's blood. And when you measure a total testosterone, when you get a blood test, which is absolutely the standard of care, if you want to know a testosterone level, you do not get saliva, you get blood, a blood test from a major lab. And it's very important that you get it from a good quality lab because testosterone assays are not uniform at all labs. So you might want to even talk to whoever's the prescriber and find out, well, what kind of an assay for testosterone? Is it really a good, valid assay? This is really important. So you want to know where it comes from because this affects what happens to it. Well, it turns out that as we age, the adrenal gland has a section of it called the zona reticularis where the androgens are produced, and with aging, that area actually kind of shrivels. So you do statistically, as a human, male and female, make less of these adrenal androgens as you age. Now, what about from the ovaries? It's really important to know that the ovaries can produce testosterone throughout the lifespan of a woman, and they do not depend on having eggs to be made from the ovary, and in fact, they do not decline at menopause. So there's so many doctors, and I see patients coming into my office, and they immediately, automatically, were given testosterone because they're going into menopause, as if that comes along automatically. Now, the reality is that's not true. Some women do benefit from testosterone, and it may predate when they go through menopause. Other women actually may not need any. In fact, what they may actually do better with is taking an adrenal precursor like DHEA, for which we'll talk about another time, but there's good data that that is also very good for prolonging ovarian lifespan if you started early enough, and also that it's good for the musculoskeletal system as well. When we look at testosterone coming from the ovaries, it's so important, as I've just said, to understand that it does not change around the time of menopause by getting lower. And in fact, it may rise. The ovaries may actually produce a higher amount of testosterone. And that is one of the reasons why perimenopausal women and early menopausal women will often say, what is happening? My hair is thinning, it's finer, I'm getting like receding hairline, and I'm getting suddenly whiskers, I'm having to shave or do some other kind of method of hair removal. And sometimes it's like acne comes out. It's like, what is this? I'm going through puberty again. I'm getting acne. Why is that happening in some women? Because all estrogen, the estradiol from the ovary, is derived from testosterone produced in the ovary. The trigger to the ovary making testosterone is the pituitary hormone, LH, luteinizing hormone. The brain has sensors in the hypothalamus to estradiol circulating in the blood. When the levels decline during the perimenopause, they become irregular and the trend is down, the brain sensors say, oh, we don't have enough estradiol being produced. So it sends out the signal to the pituitary, and in turn, the pituitary puts out the signal to the ovaries that it needs to make more testosterone because that's the precursor to making estradiol. So you make the testosterone in one area of the ovary, then the testosterone moves down the assembly line to a different set of cells, the granulosa cells, where under the action of aromatase and FSH, and you need to have eggs. If you don't have eggs or good quality eggs, you're not going to be able to convert the testosterone into estradiol, the estrogen of the ovary. But the brain just knows it wants more estrogen, so it keeps putting out higher amounts of LH by talking to the pituitary. So the pituitary gets the signal from the brain, make more LH to make more testosterone, with the plan that the testosterone will convert to estradiol. But as you get more and more into the perimenopause and menopause, without enough eggs, you don't make that conversion. So you have too little estrogen and too much testosterone. So the last thing those women need is more testosterone. What also happens with aging, and that's why even though testosterone levels do tend to go down with aging from the ovaries and from the adrenal. So you do tend to make less with aging. It's like everything kind of goes down as you age. But that doesn't necessarily mean you want to supplement with testosterone. Why is that? Because about 99% of testosterone circulating in the blood is bound to predominantly sex hormone binding globulin. A little bit is loosely bound to albumin. But what's held on by sex hormone binding globulin, it's like crazy glue. So that testosterone is like imprisoned by the sex hormone binding globulin. So it's not free or available to act on the tissues because it's bound up, held tightly, like, hostage by the sex hormone binding globulin. What causes you to make sex hormone binding globulin, which is made by the liver? Well, it turns out that estrogen increases sex hormone binding globulin. And we now know that as you age and you make less estrogen, the sex hormone binding globulin tends to go down, so you have more available testosterone that's unbound to act on the tissues. And remember, 99% of testosterone is bound, so even a little bit less that is unbound can have dramatic differences in the effects. So it's the unbound testosterone that has the effect on the tissue, not the bound or to the sex hormone binding globulin testosterone. That's why also some women will have all of these androgen excess symptoms as they go into menopause. If you have ever seen a very elderly, doesn't have to be very medium elderly woman who say, your Aunt May or whatever, or she could be in a nursing home, or you just see her and she hasn't been doing a lot, of dealing with facial hair, then you'll see these elderly women having all these whiskers and really fine, thin hair. You see all their scalp. So, why is that happening? Are they making enormous amounts of testosterone? Do you want to give them a bunch of testosterone? Well, maybe, maybe not. But the reality is that what's happening is that they have not a ton of testosterone being produced at an elderly age because the adrenal part that's making it is shriveling, and the ovary tends to make somewhat less with aging, like everything goes down, as I said. But they have lower sex hormone binding globulin, more unbound testosterone, unopposed by the estrogen now, and you get those androgenic effects. So that's a big deal. No woman wants to have whiskers and shave all the time or deal with that and lose their hair. That's like a really bad self-esteem thing. So it's important to understand that throwing a lot of testosterone at an aging woman may not make them happy, okay? That doesn't mean testosterone isn't important. Of course, my really strong opinion is that you give always estradiol to women who are perimenopause and menopause because they need that estradiol to trigger the liver to make sex hormone binding globulin, so all's right with the world, and for a host of other reasons. If a woman is young, like premenopausal, but her testosterone is really low, which can happen. I'm not opposed to testing. I love testing. And you can give a woman who is not even perimenopausal some testosterone supplementation if it's documented and she has certain symptoms. We'll talk about that in a second. But that woman that you're giving the testosterone to should have plenty of endogenous or self-made estradiol. You don't give testosterone and not have adequate estrogen on board in that woman's body to help regulate the release of it and the function of it. It's really important to know testosterone lowers the function of estrogen receptors. So if you're getting an older woman and you just give her a bunch of testosterone and no estradiol, what estradiol she now has, which is not enough, is not going to work well because the receptors are not receiving properly. So remember, a hormone has to bind into a receptor to create an effect. That's the majority of how the ways that hormones work. And if that receptor isn't like letting the hormone in properly to turn on the switches that need to be turned on that are going to produce effects in the cell, then it's just like you don't have more or enough of that estrogen, the product that's binding, called the ligand that binds into the receptor. So if testosterone is given and you don't have adequate estrogen, what estrogen you have is going to work less well. So that is not a good thing. All hormones have to be in the right amounts and the right rhythms. And testosterone as well needs to be given in the recipe of all the different hormones. So that's really important to know, that testosterone can go down because predominantly from the adrenal gland, the zona reticularis kind of shriveling and getting older and not making as many androgens, which includes 25% of the circulating testosterone directly made by the adrenal goes down with aging, and it does not have anything to do with menopausal timing. It just tends to go down. Now, what are some of the other things I mentioned that testosterone can do? I mentioned bone and muscle health. Pretty much everyone knows that. What's another one? How about libido or sex drive? And in fact, that is the only approved, we do what we think is right, of course, but that's the only officially approved use for testosterone is related to sex drive. It's called hypoactive sexual desire disorder. Well, how do you define that condition? A woman has to have low sex drive and she feels unhappy about it. A woman who has low sex drive and says, I don't care, my life is fine, that doesn't count, and she doesn't have that hypoactive sexual desire disorder. You actually have to have a woman who has a low sex drive and it's making her unhappy. That's the definition of that condition. Well, there is a lot of data that testosterone can improve sex drive and sexual response, but it's not a direct, obvious thing. In fact, if you measure testosterone and DHEAS levels, and you just do like a random questionnaire, like how's your sex drive, how's your sexual response, guess what happens? They actually don't correlate. But if a woman has low testosterone or low DHEAS and she has hypoactive sexual desire disorder, it definitely may help if you supplement with the androgens. So, but just so you know, if you didn't know what the woman's status was regarding her sex drive or sexual performance, and all you did was measure those androgens level, you would not see a correlation. Isn't that it's amazing, but it's just what it is. Why is that? Because sex drive and sexual response in a woman is way more complex than just testosterone level, much more complex. By the way, I talk about this all the time. Estradiol has a big role in sexual desire and sexual response in women through different mechanisms that we'll talk about another time. So that's another reason why just giving testosterone makes no sense. Why do I keep coming back to that? Because for some reason, it's nutty to me, there are doctors out there, well-meaning, who just give dramatically high doses of testosterone to women. I don't know where they're coming from. They're not trying to do a transformation from a female to a male, but they're just giving all this testosterone and no estrogen. They seem to think, or the thinking is, that the body will turn testosterone into estrogen, estradiol, as it needs it. It just doesn't work that way. That's why you can actually change gender by giving a lot of testosterone and suppressing the estrogen as well, but you don't have to even suppress the estrogen. You're not going to make estrogen just because you give a bunch of testosterone. It doesn't work that way. So it does not make sense to just give a ton of testosterone to a menopausal or perimenopausal woman if she is having an estradiol and progesterone deficiency state or insufficiency state. They go together. If you're going to give testosterone, make sure the woman, and that could be you, make sure that she has adequate amounts of estradiol. They work together with the receptors and so forth. So testosterone is also involved in brain function. So women who have too low a testosterone will have mood disorders and brain fog. So testosterone does matter for men's brains and women's brains. So it really is a very key, important hormone. Here's some of the problems. The research on, well, what's a good level? What's a bad level? There's like no real data. So what do I look at? And based on my long, many-year experience with patients, if I get a blood level of testosterone, I don't want the level to be in the single digits. Now, I'm not going to necessarily act on one level because you want to check things. There are reasons why we don't just accept one level, even a male, because things can change if you have a lot of inflammation. That alone can dampen down testosterone production. So you want to get a couple, but you don't want a level that is like 4 or 6. That is really low. The bottom number of the reference range, which means that only 2.5% of tested women scored below that, is usually about a 3, a 4. So a single digit is a low number. How about in the teens? Well, there is kind of a judgment call, depending on how a woman feels and also, her general state of health. So that's really important. I think it'd be nice to be 20 plus, not over the top. You don't want to get way above the top of the reference range, meaning above 97.5% of all people tested. But it's nice to be sort of in the middle ground. But here's a problem too. There is no conventional prescription testosterone that you can write a prescription for and just go to your local CVS or Walgreens or such and just fill it. You can only get for a woman that is safe through a compounding pharmacy. If you try as a woman to use a man's testosterone product, it will always be overdosed. The amount is, you cannot get the littlest amount. I mean, people do it, but they're virtually always overdosed. So you really do much better to get a compounded product. Well, that is never covered by insurance, and you have to then, pay for it out of pocket. That's how it goes. And testosterone is now a controlled substance. Like if I was prescribing morphine pills or an opioid like codeine pill, it's a controlled substance because men were sometimes doping on it. I guess women too. I know there was a question of that way back in the Olympics with East Germans, maybe now with others. We won't go there. Okay, so we don't want to have people abuse anything, but it makes it more complex when a drug is considered a controlled substance, like a narcotic. So it makes it harder to prescribe. So that's one of the problems with testosterone. But DHEA, weirdly enough, can be given as a prescription, or it can be given over the counter. Go figure that. Nobody ever explained why a hormone from the adrenal gland, DHEA, is over the counter, like I said, or it can be given from a compounding pharmacy. So for some people, if they have a lower sex drive or they have some bone or a muscle deficiency, they may want to try some DHEA first, just because it's so much easier and more affordable to acquire. Although DHEA, as I said, because it's over the counter, or it could be from a compounding pharmacy, generally speaking, it's not usually covered by insurance either, but still tends to be more affordable. So testosterone is an important hormone in women. Women make a lot of it. It does tend to decline with aging, primarily by decreased production from the adrenal gland and some from the ovary. The ovaries make testosterone for the entire lifespan of a woman. The levels do not go down around menopause. There are many articles showing there is no decline, and there may be even a rise because of the brain stimulation to the pituitary to make more LH, luteinizing hormone, causing the ovaries to make more testosterone. In addition, it's important to know that the amount of testosterone that acts is the amount that's unbound, or the available or free testosterone, which correlates to the amount of sex hormone binding globulin, which will go down, allowing more unbound testosterone to act on the tissues when estrogen production goes down. Now, what else can lower sex hormone binding globulin that can allow even a normal or even a bit low testosterone to cause elevated type testosterone effects on the tissue? Because less is bound because you have less sex hormone binding globulin. Well, it turns out that obesity and insulin resistance that can go into prediabetes and diabetes will lower the production of sex hormone binding globulin from the liver. Systemic body-wide inflammation will lower the production of sex hormone binding globulin, which is one reason why women who are obese tend to have more acne and facial hair and hair thinning. It doesn't mean that they're making more testosterone or other androgens. What it means in most cases is that they have inflammation and they have insulin resistance and they have lowered levels of sex hormone binding globulin. So what blood test should you get? You should get sex hormone binding globulin and you should get a total testosterone. The best way to know how much unbound or available free testosterone is there are formulas that can be used looking at a combination of total testosterone and sex hormone binding globulin. But in reality, if you have a low sex hormone binding globulin at the very bottom 25 percentile, then you know you're going to have more free or unbound than you should have in an ideal world. You can order free testosterone from labs, but the problem is that that's not a very precise test because in women, those levels are so low, it's hard for labs to accurately measure them. So feel free to order it, but just recognize that they're not always completely reliable because of the small numbers. But sex hormone binding globulin is very reliable, and if you have a good lab, a good assay, total testosterone is also reliable. But it's important to know where it comes from, what it does. It's important, by the way, as well for cardiovascular health, brain health, musculoskeletal health, mood, and cognition. So it's really a widespread, important hormone. Testosterone matters, but that doesn't mean we indiscriminately give it to every woman. If you have a lot of unbound testosterone, even if the total is not very high, you're going to get more acne, more facial hair, more hair thinning, and you're not going to make your patient very happy. And if you're the patient, you're not going to be very happy if you have a lot of unbound testosterone causing troubles. So let's keep in mind all of that and talk to your doctor about testosterone.